Welcome to the Mastering Therapy podcast with me, Dr. Natalie Stott, clinical psychologist. This is a show for psychologists, psychotherapists and counsellors who are looking to build on their therapy skills, increase confidence in working with clients, and be inspired by alternative models, tools and ways of working. Join my guests and me as we learn from one another and aim to take insights and put them into action. I've got with me Dr. Hayley Macgregor, who works predominantly with adolescents but has a background in neuroscience and clinical psychology. I thought she'd be somebody great to give us a bit of an overview of what we need to be aware of, how you talk to somebody about certain psychological concepts who maybe have a diagnosis of autism or ADHD. I felt this was important because a lot of us don't pick our therapy clients. If you're in the NHS, you'll maybe get a referral, or if you're an associate, you won't necessarily have a conversation with the person that you're going to be working with initially. I've noticed definitely in my work, more and more people are either referencing neurodivergence on the referral, which is, I think, a great thing that there's a greater amount of awareness, but we're not always trained in it. I don't know about you, but on my clinical training, there were certainly days on diversity, but there wasn't much attention paid to neurodivergence in particular, and maybe how you need to adapt your language or models to work with this population. So today's going to be about things to consider and think about when we are working with this population. So welcome to Hayley.
Thanks so much for having me, Nat.
Do you want to just say a little bit about where you are working at the moment and a little bit about your background?
So at the moment I work privately and I work with neurodivergent adolescents, some adults who have a trauma history, and adolescents who are neurotypical but experience anxiety, depression or OCD. So I have a really varied caseload. And prior to this, I was also working in the CAMS neuro team. So my role was in assessing for autism and or ADHD.
I think it's going to be really helpful that you can draw on working with so many different client groups. And this is obviously a field that you're experienced in, both working privately and in the NHS. The thing that came to my mind when thinking about this is for people like myself who don't have specialist training in this area, I might get a referral and it might say, please see this lady who has a diagnosis of ADHD. When we get a referral like that, what do you think are the important things to consider? Do you do anything differently? Things that you need to think about in the first session that maybe for someone who's neurotypical, you might not?
Yes, there are. And in hindsight, having more with a neurodivergent population, I think I would probably do more of this now with neurotypical people as well, because it would be really useful to consider some of these factors, I think, for all of us in terms of what would make our environment and our interactions as comfortable as possible in those first couple of sessions. So I'll originally get a referral through. I won't assume that the young person, like the teenager, will want to necessarily talk to me directly without a parent there. So I'll always ask, would you like to do a phone call, a video call? That's my initial response. And then once we've decided what they want, for example, if there's a video call, I'll set that video call up where possible to be in one of the rooms that I would use so that the young person has an idea of the environment that they'll be coming into. Would you like your parents there? So that they have options. I have normally been given a small paragraph of information, so that I haven't had much information about that young person. If their parents have said, or they've recently received the diagnosis of autism or ADHD, I will then ask in that first call what that has been like for you. Because then I know this is a young person who's thinking, gosh, this has really turned my world upside down, or it's been the best news ever, but I actually don't really understand what it means. Have they had any support in understanding what that means for them? And one of the first questions, it's not really a question, I state my intention, which is I would like to make these sessions feel as comfortable as possible for you. What do you think would help to do that? And I would give them some prompts. So for example, time of day in terms of your energy levels, whether we turn the lights on and off, whether you have any sensory preferences to lighting, the temperature of the room, whether you need a steady breeze coming in. Would you like to bring some fidget toys or kind of molding clay or therapy? You're very welcome to bring snacks and refreshments. So essentially I'm giving that young person an opportunity from the offset to tell me, as much as they're aware of this moment in time, what would make them feel comfortable in the session. And I will also say that there is not necessarily an expectation that our interactions are always verbal. If necessary, we could speak through your parents as being a bit of a translator as a starting point, through you modelling out interactions with your clay, through drawing or writing, so that you feel that you can communicate in a way that is comfortable for you. And I'm not going to put neurotypical expectations on our interactions. So if it's uncomfortable to have sustained eye contact with me, that's okay. I'm hopefully giving them permission from the offset to not have to mask and fit neurotypical expectations, so I can hopefully see them being truly themselves, which obviously they're not going to do in the first couple of sessions until they trust me, but I'm giving them the opportunity.
What I'm thinking about as you're talking is how it's communicating this confidence that I get you, I understand that there might be certain preferences or there might be difference, and that difference is accepted and welcomed.
Yes, I think it's unusual for people who are neurotypical to think about how I might adjust my style of communication and interaction such that I am considering your preferences, like your sensory preferences, your communication preferences, rather than assuming that you can just fit in with me. And so I'm trying to model the idea of self-understanding, self-acceptance. I really feel quite passionate that young people shouldn't have to mask their differences in order to be accepted. So I try and open that up and create, as much as possible, a sense of, I'm being really curious here, you tell me what you need and I'll follow your lead.
And how much has this come from your experience? Is that something that clients have shared? Oh, I found it really helpful when you did XYZ.
I was really aware in starting my NHS job, I was in this assessment service for 2 years, that sometimes I would start a conversation with a young person, I would feel like we're not connecting. There's some form of breakdown of communication here in some way. And it's because I was communicating in a very traditionally neurotypical sense. So with eye contact, lots of gestures, lots of open questions or multiple layered questions. And that was in a way that wouldn't be well received by somebody who has social communication differences, in that they would want one question to answer and process thoroughly at a time, possibly, and might not always understand my intentions if I speak in a very convoluted way. I've adapted my style over time.
And we all know that as psychologists, aren't we? Speaking rhythms and rhymes. And
we do. And I still, to this day, because that is the way I speak with my friends, and majority of my friends are neurotypical. So actually I have to check myself, and I will be really transparent in the sessions. And I will say, I see that I've asked you too many questions in one go there. So let's pick one at a time. So the first question is, and I go from there.
Is that ever difficult for some people? Maybe some people come and they're very assertive and know exactly what they want. And for some people, this might be the first environment that has actually considered their needs and preferences. And for those that are maybe not so confident, or who might feel a bit overwhelmed by, gosh, do I want snacks? Do I want a breeze? Is that just part of the therapeutic relationship developing, that you work that out over a number of sessions?
Yeah, absolutely. And I would say that 90% of my clients, this opportunity to consider what are their preferences has not necessarily been thought of before. And they haven't necessarily given themselves that permission because they've spent years masking their difficulties to try and fit in, to not stand out, to prevent them from being bullied or teased or judged negatively.
This is so valuable. And obviously you've got your experience to draw upon. But is there anything that you can recommend that people might be able to follow, or any resource they can use in order to explore this kind of a conversation?
So a really useful way of opening this up is to consider the autism spectrum wheel, in that it talks about all sorts of features of autism, and a person can talk about each one of those in turn. I really love doing that, because it can be a whole session where you can think about, what are your sensory preferences? What is your style of communication? What helps you to feel more comfortable in an environment? Your special interests, what are you really into? What are your values? So you can get so much from that exercise, and you can really understand the way that person makes sense of the world and their relationships through that exercise. And through that, it becomes quite apparent that actually I become really overwhelmed in certain situations. Why? What is it about that situation? And then it gives you material for future sessions to think about. So in a future session, we might need to think about your sensory profile and what lead to sensory overload, and how might you compensate for that?
For those people that don't know the autism wheel, can you just explain where that's from, how you came about that?
I learned about this in my previous role in the NHS, and it was often used to help parents understand the various different features of autism and to consider that a person's presentation may vary over time. So, for example, one of the parts of the wheel is looking at emotional regulation. And it might be the fact that their child or their teenager at the moment is very dysregulated, but should they learn strategies to consider what helps them to regulate their emotions, or even to understand their emotions, because some might not label emotions in the same way that we would. They might instead label them with sounds or colours. And that is really useful to consider in itself. What you can see when you colour this in is you can see that at the moment, these are the areas where I feel like I'm really sure about what my special interests are. I'm really sure about my communication preferences, but I'm really unsure about how to manage my emotions, or I really struggle with sensory overwhelm. And I'm not sure what skills I can learn to equip myself to feel more regulated. So it gives us ideas of goals and priorities in terms of our intervention, but it also shows how much you consider some of the traits of strength or a need very much vary over time.
Yeah.
So it's not a static presentation. It's very much a presentation that is changing over time. Actually, I think it would be really useful if anybody thinks that they may be autistic, then it would be useful to have a look at, because it highlights features of autism in a way that I think is far more accessible than following a DSM criteria to look into it. There is a way, I suppose, to map out what you notice in yourself, which might lead you to thinking that you may be autistic.
So once you've established that initial relationship with somebody, you've got a really good idea of their preferences and how they're going to work with you best. I'm imagining that some of the more typical therapeutic models where there's a massive emphasis on being able to articulate emotions and use verbal communication. Have you come up against any hurdles when you're maybe following a certain model, and use anything in particular to adapt it? What other things that you've come across would be important to understand or think about?
I suppose as a general point to start off with, I wouldn't necessarily be able to say this would or wouldn't work. I very much feel that once I get to know my client, you'll know what will fit with them based on, once you understand what their cognitive level is, how aware they are of emotions, how they can communicate their emotions, and what way they communicate their emotions. Then we can start to think about some of the typical resources that we might use with neurotypical people. But there's also a very handy neurodivergent friendly workbook of DBT skills, which I would say is a key reference tool for me. It's written by Sonny J. Wise, a lived experience educator. They consider DBT in terms of mindfulness, distress tolerance, emotional regulation, managing sensory needs, but each module is considered through a neurodivergent lens. So, for example, you mentioned about emotion. So for emotional regulation, you might start by thinking about, well, how do you communicate your emotions? And I work with somebody who we actually did an emotional dictionary. So we looked at positive and negative feelings in general, but her understanding of neurotypical labels for emotions wasn't really present. Instead, she understood emotions through colours. She felt emotions through different colours or sounds. So yellow would represent happy moments. So you would be asking, oh, what colours have showed up for you this morning? But essentially that would be the same as what emotions would you feel? Yeah. And what were you doing? Like, quite directly, I was stroking my cat and then I was cuddling my squishmallow. Okay, great. So I've got a sense of how your morning's been, but we've not mentioned the word happy, excited, soothed, relaxed, or sometimes uses words such as fizzy. And fizzy means there's a range of different emotions showing up, but it's positive. It's a nice experience. So it's a translation experience, I think, to start off with, to make sure you understand how that young person will be able to communicate to you how they've been feeling in a way that is accessible to them. So I think that's your starting point if you're thinking about emotions. And then in terms of physical feelings, some of my clients find it really difficult to get a sense of how their emotions link with bodily physical feelings. So, for example, like lust or fear feels exactly the same. And the only other thing they can experience is maybe a nauseous feeling in their stomach. And is that because they're hungry, they're anxious, they're sad? It could mean any one of those things.
Yeah, because so many of our emotions, they might feel very similar, but it's dependent on the context in terms of how you might label them, right?
Exactly. And it's also thinking, what is the role of our emotions? And often it's helping people to consider how the way they're trying to communicate our motivation, how we might be communicating that we're feeling, is it receiving information, and how does that person make sense to them in that way? So sometimes you going back to explaining primary and secondary emotions, that's something that S1E talks in their DBT skills. It's really useful in terms of teaching about emotions. That might be a whole session or a couple of sessions work. Whereas maybe in a neurotypical population, you might just assume that I know what different emotions feel like in my body. I know how to label them. I know what experience they're associated with. When I do my work, I don't assume that's already known.
I saw something recently where someone used a smartwatch when they were explaining fight or flight, explaining anxiety, that they use their smartwatch to see their heart rate, to be able to notice, oh, your heart rate's increasing. It's something that they can very physically see and then can begin to make that connection between what their body is experiencing and I guess what it's called.
And that's similar to a parent of one of my young people that I see. She said that the emotional dictionary has been really powerful for their relationship and understanding at home, because she'll hear noises that her daughter's making and she'll know that, oh, okay, this is a yellow noise or an orange noise, or this is a red noise. And I know what that means. So no, I don't have to worry about that. And I now can communicate in my daughter's language so that she knows I get her, and it's so validating for her. And we were then able to use that to think about the window of tolerance, which is, I think, that a lot of us would already use in our clinical practice as neurotypical people. But now we can think about what colours would fit in your zone of tolerance and what would be the colours that would represent hyperarousal or hypoarousal. And then we can link that very much to physical cues. For example, my client, it would be more a sense of, if I'm thinking about states of hyperarousal, like not having any energy, feeling really fatigued, it's thinking, mum might ask, when have you last drank? When have you last eaten?
Because often autistic people
don't have such a strong interoceptive awareness of cues for hunger or needing the toilet. So when you think about your base needs of taking care of yourself, keeping hydrated and having nutritious food, if you're not getting that sense of I'm hungry or thirsty until the point that ghrelin is making your stomach very noisy, or your lips are sticking to your teeth because your mouth's so dry, they might be the cues at that point. Of course, you're going to feel fatigued. And it's important to recognize that, so you're not thinking, my child is very hyperaroused right now. Actually, they might be incredibly dehydrated and incredibly hungry, but they haven't picked up on those cues.
Can I just clarify, is the emotion dictionary similar to an emotional wheel?
So there's loads of emotional wheels out there which are very helpful. I started by showing my client 2 or 3 of those emotional wheels as a way when starting the emotional literacy work. And from that point forward, we then thought about the colours and sounds. So let's make a dictionary of positive, negative, and then colours and sounds and pictures to go alongside it. And then the mixed emotions, or the complex emotions, were the fizzy ones, the multicoloured dots. So it evolved. And I think that's a really important point, the importance of collaboration and co-creating the work, which we are all encouraged to do as clinical psychologists. But I think particularly with work on neurodivergent people, it has to be something that they can connect with. So following their lead in that sense is really useful.
One of the things we were discussing before we started recording was around any particular exercises that you do to orientate someone to the therapy space. Would you mind just sharing a little bit about what you do after you've established someone's sensory preferences and begun some of the work, and what your routine is as somebody comes to your practice each time?
One is in terms of check-in exercises. One of the things that we might do is some of my people have a special interest. I have one person whose special interest is Taylor Swift. She is a huge Taylor Swift fan. So at the beginning of every session, to regulate herself, we tap into her special interest. we ground her in a Taylor Swift song and we discuss it afterwards. We do mindful appreciation of Taylor Swift. We listen to it together. It's something we collaborate on, and then we set the agenda for the session. And it's really mindful. And also, I'm now a massive Taylor Swift fan as a result of it. And also to consider that when we were speaking earlier on about communication differences, some of my clients can express themselves beautifully in written, creative writing, poetry, songwriting. So in terms of their first exercise, how are the pros and cons for the week, they might be able to say 3 pros, 3 cons. And I'll say, and what poetry have you written, or what songs have you written this week? And then we listen to that. And that would be really tricky for them to say on the spot with me in the session through reciprocal conversation. But they can bring that, because they're their thoughts of the week, condensed into a poem or a song that they've written, and they share that in the session. It gives me a fantastic insight into their experiences, their thoughts about themselves and others in the world. So I think going back to the autism wheel, it's really useful to think about the traits of and how some of these special interests or being able to be hyperfixated on something can work to huge advantage in a therapeutic session, because we can consider what they have focused on that week in terms of a song they've been writing, and I can get a real insight into what their life's been like.
Just before we finish, I wanted to touch on this idea that we really have such a short amount of time with someone in the therapy room. And part of our role is not only helping them make sense of something in that particular moment, but what do they do moving forward? How do they take their learning and put it into place in everyday life? And so I'm wondering, when you're placing such an emphasis on preferences and these amazing realizations that people are having that might be life-changing for them, how do you encourage them to take that forward into school or into their interactions with their peers?
So you'd think about adaptations. So for each of your senses, you think about the details of what might be an example of hypersensitivity or hyposensitivity, and then adaptations you might need to make. And often this is something that clients have never thought about. So we can think about, okay, so you're saying that at school you feel really overwhelmed and quite nauseous by the end of the day. Let's consider your sensory profile in relation to your classrooms in the afternoon. And then they might say, like, I'm totally overwhelmed. I've got sensory input to the extreme through all of my senses, and it's overwhelming. So an example of hypersensitivity might be lights being very bright. And if you're catering for a class of 30 students and it's a month, you're going to need the lights on. But that actually might feel really hypersensitive for that young person. So we need to think about, how might a young person manage that? So could it be that they can utilize lamps in another quiet space? Could they sunglasses on really bright days, or fluorescent lighting instead of this intensely bright lighting? And actually that helps them to make sense of why they are so exhausted in certain environments, or have panic attacks in certain environments.
I'm imagining that, especially if you're working with children, it's really the responsibility on the adults to educate themselves and have an awareness of this. I've recently worked with a doctor who's got ADHD and dyspraxia, and she is very aware of what her needs are when work gets overwhelming. She says, I just need to get really close to the floor, and I have this blanket that really soothes me. I just make sure I take one of my heavy coats in case I do need that regulation in the middle of the day. That is obviously quite a mature response to knowing yourself, being aware of it, giving yourself that permission. But imagine that's not something a 13-year-old or even younger is going to have. So maybe they're quite reliant on their parents to put those kinds of things in place for them. But if the parent doesn't know and doesn't have those tools, they're going to be coming to us as the professionals to give them guidance on what to provide so that their sensory preferences are met.
Absolutely. I used to work with a fantastic occupational therapist in the NHS, and she recommended a book called Living Sensationally. And in this book, it helps us all be aware of what our sensory preferences are. And I think it's really useful for every single person to consider, what are my sensory preferences? What do I need when I feel really worn out at the end of a busy day? What would help me to feel more at ease when I return home? So, for example, a quiet room with no sound, maybe stroking my dog, candles on, the smell of chocolates. This is a multi-sensory experience that I'm tapping into to soothe myself. And so I think once you know what your sensory preferences are, what you're hypersensitive to, what you're hypo or hypersensitive to, then you can consider what accommodations you will need for yourself.
Yeah.
Knowing your sensory preferences, you can then create a sensory toolkit to soothe yourself.
Nice. So I think we have reached the end of our time. But Hayley, thank you so much. I have learnt a lot from just hearing you speak about your experience with clients and things to consider that I might take for granted. And I think when we're talking about neurodivergence, there are things that need to be considered regardless of your age, and that's really helpful. So we'll put reference to some of those books that you mentioned and resources in the show notes so people can have a look at that. And thank you so much.
Thank you so much for having me, Nat.
Thank you for listening to this episode of Mastering Therapy. All of the resources mentioned are available in the show notes. If you're interested in getting more information on what's been covered this season, you can sign up to our mailing list or visit the website masteringtherapy.com. If you've listened to this and you've thought of someone you think would be great to interview on the podcast, submit a recommendation on the website. I'd love to hear from you. The Mastering Therapy podcast and the information provided by me and my guests is solely intended for qualified professionals for information and educational purposes. I look forward to you joining me next time.